Greetings, and hope you are taking care during this very difficult COVID-19 situation. Thank you for joining this short video where I hope to answer the question, or at least provide some insights on how SARS coronavirus 2 causes severe COVID-19 disease. Go over some questions, quote unquote answers, because there are no really definitive answers yet, but I think we have some important clues. And this, of course, leads to more questions. So the first question is, why do older people have more severe COVID-19 disease? But it should be noted that age alone, insofar as it may imply some more weakness or generalized ill health, is not a risk. More specific conditions have a certain risk that we'll talk about. A third question, epidemiologically, is why are men more susceptible to severe COVID-19 disease? And these points are substantiated by Chinese CDC data. You can see here increased age portends a higher risk of fatality, and certain health conditions, cardiovascular, diabetes, respiratory disease, and hypertension, are also highly correlated with increased mortality. And then, as you can see here, male gender is also more susceptible to severe disease and fatality. Now, as I mentioned, it's not ill health in general, but specifically lung disease, pulmonary disease, cardiovascular disease, diabetes, and especially hypertension. What is special about these conditions? So in other words, cancer, kidney disease, liver disease, tumors, etc., are not specifically associated with higher fatality. They may be indirectly, but not as much as these conditions. In fact, the top coronavirus, Dr. Nuhan, had been noted to say that hypertension in particular is a major death risk. And what makes severe COVID-19 disease so dangerous? Why is it fatal? So you can see here an X-ray of actual COVID-19 patient in the intensive care unit. You can see the various wires here. And you see these fluffy opacities, ground glass opacities, as a radiologist call it, covering both lungs. And this is obviously not a normal situation and indicative of very impaired gas exchange, difficulty oxygenation, exchanging carbon dioxide, and mechanical ventilation, oxygen, etc., are required in these conditions. And then there is another big question. How is it that SARS coronavirus 2 is so transmissible, contagious, another word, even though it can be highly fatal in some people? And the reason why this is a mystery is that if you look at this chart of various viruses, you have the case fatality rate in the vertical direction and the infectivity, also known as the R0 on the horizontal axis. And SARS coronavirus 2 is kind of in the middle here. You have very highly fatal but relatively low transmissible Ebola. You have fairly transmissible common cold, but with a very low fatality rate, of course. And then highly transmissible measles that also have a relatively low fatality rate. In general, you can see by this line that there's an inverse relationship between transmissibility and fatality. In other words, more transmissibility, more contagious, generally is less fatal. That would be the viruses in the lower right hand here. Less transmissible are generally viruses that are more fatal. And so SARS coronavirus 2 has a curious mix of both of these. So let's try to answer these questions. And the framework that we'll explore here is something that's been increasingly understood by various scientists around the world studying this. And it concerns the ACE system. And the ACE system, or angiotensin converting enzyme, are proteins that are found in the lungs and also other parts of the body, but highly prevalent in the lungs. And there are two of them, two of these ACE proteins. One is called ACE1, which has been well known since 1956. And ACE1, it's a complicated story, but basically is involved in increasing blood pressure. So if we have a person with high blood pressure, we inhibit ACE1 with ACE inhibitors, It's a very common medication used to reduce high blood pressure by counteracting or inhibiting ACE1. The second protein, which is less well known, in fact, it was discovered in 2000, is ACE2. And ACE2 is the opposite partner of this ACE1. It actually reduces blood pressure. And again, I'm not going to go through the mechanism of that, but it also has some effect on reducing inflammation, particularly the tail end of inflammation. We have early inflammation or late inflammation, the tail end of inflammation that leads into the repair process. So in other words, if we have less of ACE2, we may have increases in blood pressure, we may have increases in inflammation, and increases in fibrosis. This picture shows you the virus, SARS-CoV-2, and its spike protein. And the target of the spike protein is this ACE2 on the surface of lung cells, and as it turns out, other cells as well. So ACE is not just a technical thing, theoretical, that we're talking about. It is the target for SARS coronavirus 2. So there was one article, and there are several articles about this in Lancet. Are patients with hypertension, diabetes mellitus at increased risk for COVID-19 infections? So there are actually two issues. One is risk of infection and risk of serious disease. So I'll address both of these, but this paper in particular looks at the risk of infection. So let's start in the lower left hand here. We have people with disease, hypertension, diabetes, cardiovascular disease. They will be on these ACE inhibitors. The ACE inhibitor counteracts ACE1 and thereby counteracts the increase in blood pressure, so it lowers the blood pressure. Now, because these are in balance, if you're counteracting the ACE1, the ACE2 in these patients is actually increased. Although, even though the absolute numbers are increased, relatively speaking, there might be some challenges around the balance, and we'll talk about that shortly. Now, these increased ACE2, you can imagine the target being more prevalent, makes it easier to be infected with SARS coronavirus 2. That's the point of this article. They argue that because of the increased ACE2, they're at increased risk of COVID-19 infection. I also think they're at increased risk, actually, of the serious consequences, not just increased risk of infection, but also increased risk of the serious consequences. So let's develop that. So as the virus infects these cells that have ACE2, two things happen. One is the virus is internalized, enters into the cell, and by that process, again, I'm not going to talk about the details, but by that process, the ACE2 is also brought in. The ACE2 has to be on the surface to function, and so effectively you're reducing the ACE2 levels. And if you reduce the levels of ACE2, you upset this blood pressure control, and you do the opposite of decreasing inflammation, you can increase inflammation. The second problem is that these ACE2 receptors are located on type 2 pneumocytes, which are very important cells in the lung that produce what's called surfactant. Surfactant is a kind of soap-like substance that keeps the gas exchanging regions of the deeper lungs, called the alveoli, open and able to exchange gas. Without surfactant, then the gas exchange is highly compromised. You need mechanical ventilation and oxygen. The other issue is ACE2 reduces inflammation, but if you reduce the ACE2, then the inflammation comes, particularly this fibrotic phase, and you get the characteristic X-ray images, the medical imaging, with these patchy infiltrates, the ground glass opacities. And that too compromises lung function as well. So here's some points and predictions from these concepts. One is hemodynamics. The ACE system, as you can see, both ACE1 and ACE2 are critical elements of the maintenance of blood pressure in an opposing way. And their balance and sufficient amounts is very important for the maintenance of the blood pressure and other cardiovascular parameters. So one prediction is, unlike severe influenza, which infects the lung epithelia in general, the surfaces of the lung, and is more of a large-scale inflammatory process. One reason why you have all the aches and pains with influenza as compared to just more of a cough with COVID-19. Severe COVID-19 is likely to involve significant hemodynamic instability. And this is one reason why the severe case ends up in the intensive care unit. So intensive care specialists are obviously very well trained in that, but this may be more hemodynamically complex, cardiovascularly complex than your usual respiratory infection, your usual severe respiratory infection. Second prediction related to hemodynamics is that while people on ACE might have, ACE inhibitors might have increased ACE2, their reserve capacity is likely to be limited. In other words, the ACE system, and by extension, the hemodynamic stability, will be quite brittle and vulnerable. Second implication is around the oxygenation issue. So the loss of these surfactant-producing type 2 pneumocytes will result in alveoli collapse and compromising gas exchange. This is actually very well known in infants. So with COVID-19, mostly it's adults, as we know, older adults, but infants, especially preterm neonates, premature neonates, have reduced surfactant production because in fetal development, the surfactants develop quite late. So intensive care specialists treating adults should learn as much as possible from their neonatal colleagues in intensive care on how to manage this. In fact, these neonatal premature infants have severe respiratory distress, but they're not infections. They're focused essentially on the lack of these pneumocytes. And COVID, the SARS coronavirus 2 virus is attacking directly that. And then the third implication is around this whole fibrosis question. So ACE2 decreases inflammation and inhibits the ensuing repair process in the lung. So decreased ACE2 will increase lung fibrosis, perhaps even earlier than the usual pulmonary fibrotic pathologies. So what do we mean by fibrosis? It's kind of a repair process that follows an injury. So the infection happens, you have a repair process, and this repair process usually unfolds over weeks, but we may be seeing that in a more aggressive way in COVID-19. So because this fibrosis also has certain imaging characteristics, chest X-ray and CT imaging of COVID-19 is likely to appear quite different from other forms of respiratory distress syndrome, whether it be influenza, infectious, or so forth. So because laboratory testing may be difficult or delayed, time-consuming, chest X-ray or CT should be considered. Now, if that's not so easy, so there has to be some form of additional study, adjuncts such as deep learning, artificial intelligence, etc., to tease out this signal of combined surfactant loss, classical respiratory distress syndrome with fibrosis. Last prediction, there's been some advice floating around the internet about the importance of a dry cough as a sign of COVID-19 infection, and also the so-called 10-second hold your breath rule. You hold your breath for 10 seconds. If it gets very uncomfortable, unusually uncomfortable, then that might suggest this process going on. So given what has been described here, there may be some validity to these ideas and a useful way to differentiate on a clinical basis for such COVID-19 infection from other similar respiratory conditions. So just to summarize, why do older people have more COVID-19 disease? So it's a little bit tricky. It's not just about, I sense, different ACE levels. ACE levels, ACE2 levels, I should say, go down. ACE levels in general go down with age. So older people have less ACE2, which means that while they may be less easily infected, except in the case with the ACE inhibitors, they are more vulnerable. So they have less reserve. And as their type 2 pneumocytes are killed, their ACE2 levels will further fall. In some young people, obviously, if you lose a lot of these pneumocytes, they will also get in trouble. And of course, older people tend to have more of these conditions that we talked about before. So the vulnerability to the disease is not about some general weakness related to age, but something specific with the hemodynamic balance that's mediated by this ACE system and the lung protection with respect to ACE2 as well. So why is that men are more susceptible to severe COVID-19 disease? So there's been some studies showing that women actually have more ACE2 protein. So this relates to estrogen, and so they have more reserve. So although the positive effect of estrogen on ACE2 might go down with menopause, the higher ACE2 may make it easier to be infected, but make it more resistant to severe disease, and so the death rate will be lower. So what is so special about these specific conditions, lung disease, cardiovascular disease, diabetes, especially hypertension? Again, we're talking about a specific vulnerability with respect to overall cardiovascular function, which compromise this control point, the ACE control point for cardiovascular function. And so if people are suddenly decreased in their ACE2, they can become hemodynamically compromised. So what makes severe COVID-19 disease so dangerous? Why is it so fatal? So there are two things in biology, well, many concepts in biology, of course, but two key concepts: the concept of a critical control point. We saw that with HIV, for example, which infected T4 cells, CD4 cells that were the control point for the immune system, and that's why you had acquired immunodeficiency syndrome, as HIV was killing those key control points. Now, the ACE system, both the positive and the negative, or the increasing or the decreasing of the blood pressure, ACE1 and ACE2 respectively, that's one of these critical control points for the cardiovascular system. And it turns out that, of course, these ACE2 is expressed on these type 2 pneumocytes that are so critical for lung function. And finally, ACE2 is related to lung repair and inflammation, that this SARS coronavirus 2 has picked a very vulnerable point. And not for everybody. As I mentioned, the fatality rate is not high across the board, but under certain circumstances, it is very potent, much like a kind of deja vu when AIDS was first coming out, or HIV was first coming out. People were really shocked how that virus somehow picked a target that was a key vulnerability. And I'm, really afraid to think that this is a similar sort of situation. So how about the big question about this inverse relationship between transmissibility and fatality? So you recall this chart here. So one of the reasons why SARS coronavirus 2 can be both is, first of all, ACE2 is found in nearly all tissues. This is a chart of many tissues, all the way from kidney, stomach, liver, and of course lung here. And then this is the oral cavity. This is the tongue, the floor of the mouth, the base of the tongue, other sites. So ACE2 is found also in the upper respiratory tract. It may not have this critical central role, but clearly that helps it to be effective. ACE2 is abundant in young people and those without cardiovascular pulmonary disease, specifically the ACE2 and ACE inhibitors. So SARS coronavirus 2 achieves both transmissibility through younger people and fatality through these vulnerable individuals. So we need to think about it differently. It's not like the virus is somehow some monster virus out here, very transmissible and very fatal. No, it's down here, but it segments into these two populations, two categories, to have fatality or highly severe disease in certain group related to this ACE2. It's coming more clear around that, and less fatal in these younger populations and without the risk factors. So what can we do? Well, in terms of medicine, we need to consider severe COVID-19 almost as a separate disease entity. It's not just a matter of degree or a worst case of the benign infection. ACE inhibitors and related angiotensin receptor blockers will increase ACE2. We mentioned that. So you kind of pushing down the system and the ACE2 will pop up. That potentially risks increases the risk of infection. So doctors may want to reconsider these for their vulnerable patients and consider using other hypertensives, antihypertensives. That was speculated in the Lancet report. But it's tricky because since ACE inhibitors also upregulate the ACE2, which is protective, as I mentioned, then once someone has severe COVID-19 or leading to severe COVID-19, it may not be advisable to take them off. So this is very tricky, and this is not to be considered medical advice. You should always consider your own case with your own doctor. This is more thoughts that specialists should be thinking about. There have been some suggestions that the lung damage, especially difficulty breathing, can occur even with milder cases or recovered cases of COVID-19. And I think this may be a result of the earlier fibrosis process that's been described. Again, in this case, mechanisms to increase ACE2, which I'll mention below, and perhaps for those on ACE inhibitors to change their medications should be considered. So increasing ACE2 might be an important approach to this. In terms of public health, social distancing always remains absolutely critical, especially for older and vulnerable individuals. We should study all of these susceptibilities in more detail, especially the gender and medical and medication history. A lot of public health is around contact tracing and all sorts of exposures. I think we need to see this intersection with the fundamental physiology as well to understand how to manage that. And in terms of science, obviously developing vaccines, early populations with testing this should be with the younger individuals, which is more transmissible. We should learn more about this ACE1 and ACE2 system. As I mentioned, ACE2 has just been recently discovered, less than 20 years. Genomic correlations with ACE polymorphism, genetic variability. So some people may be more susceptible or less susceptible. And we should know that there are actually no cures for viruses. I don't mean to be panicky or anything, but that's just a fact. Viruses are actually not living as opposed to bacteria. So you can't really kill them. I mean, you can destroy them with alcohol wipes and so forth. But effectively, the way viruses are eliminated from the body is from the immune system. So there are antivirals, there are treatments, but not cures. And these treatments slow down the virus so the immune system can clear it. The other treatment for viral infection, of course, is supportive therapy. And clearly, because this virus is affecting such critical functions around cardiovascular health and lung function, this supportive therapy to tide people over is very important. So for this latter, supportive therapy, we need to find ways to support the ACE1, ACE2 control and balance. And how can we increase ACE2? Can we infuse it directly? Can we inhale it? Can we maybe give a dose of estrogen to increase it, or other factors, other medicines to increase ACE2? Inhibiting ACE1 has been around for a long time. As I mentioned, ACE inhibitors, ACE1 inhibitors have been around since the middle 70s, 1970s. The flip side, you can inhibit the protein, but to increase the protein levels is quite challenging. So methods to increase ACE2, whatever they may be, should be explored, and we must find a way for that. And that's also for younger people too, not just the susceptible ones, but who might be actually getting some damage from this infection. So thank you very much for listening. I hope this was helpful. And I guess the mark of being helpful is raise even more questions and stimulate more thought. As they say, knowledge is power. It's not perfect, but I think the more we have, the better we'll be. So please take care. And if you have any questions, you can email me, ogangarel@gmail.com. I'm also on LinkedIn. Thank you very much and take care.